pendant que tout le monde prend place, j'aimerais juste vous encourager à aller sur Slido, même si on ne pose pas toutes les questions qui sont sur Slido. Ça peut être intéressant pour vous de les voir. Vous pouvez les liker, ça les fait remonter tout en haut. Et voilà. Mais je vais répéter ça encore une fois parce que je crois que personne n'est trop attentif. Merci de prendre place le plus vite possible.
Nimm bitte Platz, so können wir weitermachen.
Donc je vais recommencer mon histoire sur Slido. Ouais. S'il vous plaît, prenez place, comme ça on peut commencer. Toutes les personnes debout, s'il vous plaît, prenez place. Ah.
Wir bitten alle abzusitzen.
Oui, prenez place, s'il vous plaît. Voilà, merci, on va bientôt commencer la session. Je vous rappelle que vous pouvez poser les questions sur Slido. Elles ne seront pas toutes posées, évidemment, parce que vous en avez beaucoup. Vous pouvez les retrouver dans les archives. Si vous aimez une question, vous pouvez la liker. Elle va remonter tout en haut du classement. Voilà, je vous encourage à utiliser. Tu peux le dire en allemand.
Ja, ihr könnt gerne noch auf Slido gehen und dort eure Fragen stellen. Und wenn ihr gute Fragen stellt, ihr könnt ein Like machen und das wird dann auch hinaufgehen. So, fine. So I'm very happy to present you Andrea Mosler. She is a specialist for sport physiotherapy and also for practice and studies. She is a senior research fellow at the Trobe University, Melbourne, in Australia. And 2080, she made her PhD in Aspetar with the theme risk factors for hip and groin pain. She had a lot of experience also with the Australian Institute of Sports, and she was also at the Olympic Games 2000, 2004, and 2008. Please,
Thank you.
Andrea.
Thank you. So first of all, I just want to say a very warm thank you for inviting me back to this amazing conference. It's so lovely to see all these terrific faces out there. Thank you, of course, to the organising committee and the best host ever, Mario Bazzini. Thank you. So when we are talking about best practice, I decided to divide this into 5 different categories. So starting off with terminology, because there's been an enormous amount of work in terminology in the hip and groin space over the last 10 years. Diagnosis, assessment of impairments or physical capacity, management, and I cannot do a talk about best practice for hip and groin pain without discussing prevention, robustness, sorry, Phil. But last time I was here, I did a whole presentation on prevention of hip and groin injuries, so I've only really done a very short summary at the end, but you're welcome to see last presentation from 4 years ago online. So starting with terminology, as we all know, the hip and groin area has really been plagued with this terrible variability in terms, and depending on which country you're practiced in, the same injury will be called different things in the country next door to you. So this created a massive challenge to synthesise the literature and provide clinical guidelines to physiotherapists and sports medicine practitioners there wanting to know what to do with their athletes. So in 2014, a bunch of, let's call it, men, except for one woman, met in Doha, November 2014, experts in hip and groin injuries, and came up with a meeting and a consensus on terminology and definitions for groin pain in athletes. And we're all now familiar with these categories of inguinal-related, psoas-related, hip-related, pubic-related and adductor-related groin pain. The 4 clinical entities are the inguinal, psoas, pubic and adductor, and hip-related is an additional category, and other are basically medical causes of groin pain. So this has been really handy in terms of being able to synthesise literature and talk a common language around the world. The terms that we don't want people to use are some of these really nondescript terms which don't have very clear diagnostic categories or clinical tests. How well has this categorisation or classification system been adopted? Well, they did a Delphi survey of the actual experts that were there in the room and an international survey of clinicians working with groin pain, and found that after 5 years, the classification system has been adopted by around 80% of the Doha Agreement meeting experts. One would have hoped it would be 100, but it's not, it's 80, and around 60% of international clinicians. So it's doing okay, 5 years. It's not that much time to translate into change clinical practice, but probably needs to do a little better, yeah? We want that to be more standardised throughout the world. The problem was, from the Doha Agreement, is there really wasn't a clear definition of hip-related pain. And this was the definition that was given in the Doha Agreement. Clinical suspicion that the hip joint's the source of groin pain, either through history or clinical examination. Doesn't give you a lot of details. So moving on from that, the Warwick Agreement in 2016 occurred, and here we had a really nice, clear definition for femoroacetabular impingement syndrome. A motion-related clinical hip disorder with a triad of symptoms, clinical signs and imaging findings. And the imaging findings are of CAM and or pincer morphology. No such thing as asymptomatic FAI. Get that out of your vernacular. It doesn't exist. You have to have symptoms to have femoroacetabular impingement syndrome. If you have a CAM morphology with no symptoms, you have a CAM morphology. Easy. And then following on from that, we established in 2016 the International Hip-Related Pain Research Network. And this was because there was still this need, we identified this need for an international consensus to enhance collaboration across the research groups in the world, particularly when it came to hip-related pain. Lots of different things happening around the world, and we weren't necessarily coming together and solving the big problems. And we wanted to disseminate knowledge of how to manage these conditions to clinicians. So we were very blessed to have a fantastic host. We spoke at the conference and then went to Zurich and met for a couple of days at the Schultness Clinic, and 4 key consensus papers came from that meeting and 1 infographic. And the 4 main papers, the first one's on classification, diagnosis and definitions, second one on standardised measurements of physical capacity, patient-reported outcome measures and management for hip-related pain. So the relevant paper for terminology is classifications of hip-related pain. So now we can say, after imaging, hip-related pain can be categorised into FAIS, and we have lovely definitions from the Warwick Agreement, acetabular dysplasia and or hip instability. It's a little bit of a dark hole that needs to be dealt with over the next 4 or 5 years. We need to get better at defining that. And then other conditions where there is no clear bony morphological variant. So things like labral, chondral, ligamentum teres conditions, where there is no CAM morphology or pincer morphology, etc. Now, these are fairly rare. Most of the imaging findings will be in conjunction with one of those other 2 categories. Now, we've still continued to evolve, and we now have developed the Young Athletes Hip Research Collaboration, led by Dr. Paul Dykstra. And the aim of this is to increase the value and reduce waste through high-quality research on the etiology, treatment, prognosis of conditions affecting the young person's hip. Very big aims. We were hoping to meet in a live symposium in 2020 and do a Delphi agreement meeting, but something got in the way and we ended up online. And it actually was almost better, because what then happened is we had these series of webinars and we were able to share data, have nice open discussions between speakers. We had 12 webinars, so 1 a month, getting up at 4:30 in the morning in Australia. A little tough, but it was a really valuable experience for us. And in the meantime, we published this paper, which was an 8-stage process of concept analysis, where we came up with 5 defining attributes of primary CAM morphology related to tissue type, site, size, shape, and ownership. And there was also a couple of other gaps identified. First of all, there's still really inconsistent reporting of terminology, taxonomy, and how the CAM morphology is operationalised, and we wanted this to improve, and that there's a real lack of data in female athletes and understanding of the female athlete hip. So they were the two main gaps. So in 2021, we had this 2-round Delphi survey and then 2 online meetings. And we came up with a level of agreement on the definition, terminology, taxonomy and imaging outcomes, and we also ranked some research priorities. And there's a couple of papers that are in final stage of review at BJSM, so these will hopefully be published by the end of this year or early next year. Finally, we were able to meet in person in Oxford, and we had this full-day symposium, which was just wonderful to be able to meet in person after speaking online for a couple of years. And from that, we have solidified those research priorities and developed groups who will take responsibility for filling those gaps in research. And we will have another consensus paper that will develop over the rest of this year. There's a website being launched which will help this translation of information to clinicians. And there's a series of podcasts currently on JOSPT Insights, which is sort of disseminating some of this information. So look out for those. So hopefully with all of this work that's been done over the last sort of 10 years, we have improved clarity of the taxonomy and terminology, and this will lead to better understanding of the epidemiology of hip and groin pain in athletes, and we really need to find out more about the women athletes if we can. Right, so diagnosis. I'll just alert you to this clinical guidelines paper that was published in JOSP in 2018. It has a fabulous flowchart which really clearly shows the clinical entities, the other categories, when we need to screen, when imaging might be relevant. So I think this is a really nice, for those of you who are young physios, this is a really nice place to start in helping to understand where the literature is with hip and groin pain. And we have really clear methods described in the Doha Agreement paper on how to come up with these classifications. Very simple clinical diagnosis. Imaging's not needed for adductor-related groin pain, psoas-related groin pain, inguinal-related groin pain, and pubic-related groin pain. Within this paper is an updated table from the Doha Agreement to include the findings from the Warwick Agreement and the fact that if you have mechanical symptoms, you're more likely to have hip problems. These help rule it in. If you've got limited range of motion and imaging findings, help rule it in. The C sign description of area of pain and pain on sitting are some of the things that can alert you towards hip. But overall, we're pretty crap at being able to rule in the hip. Our tests have good sensitivity but really poor specificity, and they have really limited ability to rule in the hip on clinical examination. They're best used for ruling out. So in other words, if you have normal range of motion in your hip, you have a negative Fader and Faber, it's much less likely that you have a hip problem. Now, since the consensus, there's been a paper published by the group in Sweden who found in a small cross-sectional study that this prone internal rotation test, looking at range, was not so bad at differentiating between the symptomatic and asymptomatic hips. So maybe this is something that we need to look more at in the future as a potential test that could rule in hip. But small study. We know that MRI findings are found equally as much in symptomatic as asymptomatic athletes, particularly when we're looking at adductor-related groin pain, and it's quite possible that a lot of these MRI findings are more associated with soccer play rather than groin pain. Little bit of a problem when you want to use imaging for diagnosis. And we've been looking at this a lot with our force cohort. So this is the group at La Trobe. These 4 have finished their PhDs, and Rinches from Erasmus University. And just to remind you, I think Josh Heary presented this if any of you were here 4 years ago, but we have 184 football players, both Australian rules and soccer, are almost 50-50, with hip and groin pain, still playing sport. So it's quite a unique cohort because they're still active. And 55 control football players, about 20% of them are women. And at baseline, we collected things about joint structure on MRI. We did a number of patient-reported outcome measures. We followed them after 1 year, and again after 2 years with patient-reported outcome measures and MRI imaging to assess their joint structure. At baseline, we also looked at things like bony morphology and some of the clinical measures, so biomechanics and strength, range of motion, etc. So we now are actually up to 7 years. We have some that have reached 7 years. So it's been really fascinating watching this cohort, and life gets in the way. Some of them have stopped playing sport and their hips are getting better. Some of them stopped playing sport and their hips are getting worse. So it's going to be really interesting to analyse this data. We're just starting to analyse the 2-year data at the moment. But in terms of the baseline data, looking at the relationship between imaging and groin pain, there we found a relationship between 4 of the subscales of the IHOT and the size of the alpha angle only on the done view, but there was no relationship between the size of the cam morphology and Hagos or Hoos proms. In terms of joint structure, we found labral findings and cartilage findings in considerable number of the hips, and this was really independent of symptoms. So not a strong relationship between symptoms and imaging findings, which is what we're seeing in the back, it's what we're seeing in the shoulder, we're seeing this in a lot of areas of the body. Interestingly, the worse the Schomri scores, or the cartilage scores, was more associated with symptoms. So maybe when you're getting into that really higher level of imaging findings, perhaps that's more correlative with symptoms. Again, as we predict, cam morphology is present in 60 to 70% of hips, and this is regardless of symptoms. So if you play these change in direction sports during adolescence, you're more likely to get a cam morphology than not. This is a very clear message. And the alpha angle was associated with cartilage defects and labral tears, but it didn't matter whether you had a sore hip or not. If you have a high alpha angle, you're going to have changes in your hip, and it may or may not be symptomatic. So this is why at the consensus meeting we said imaging for people with hip conditions is diagnostic utility is limited, and we suggest that it's always got to be combined with symptoms and clinical signs, and the relationship is currently unclear. So that's diagnosis, a bit of a muddle. Looking at assessing impairments, things are a little bit clearer. So when we're looking at impairments, we're looking at some of the contributing factors to the presentation. Range of motion, strength, endurance, functional testing, everything that all of us are trained so well with as sports physios. So our paper really summarised the evidence on standardised measurements of physical capacity for these athletes. We identified 4 key areas. So clinical measures, everything you do in the clinic, everything you do in the lab, measures of physical activity, and returning to physical activity. And we initially just looked at sport, but then during the consensus we added in occupational demands because we felt that was relevant to our patients. So our clinical recommendations from the consensus were all voted as appropriate, apart from one, which is range of motion. There's still considerable conflicting evidence when it comes to understanding the relationship between range of motion and the presence of hip and groin pain. We were uncertain, even recommending that we can measure it clinically. It's not known whether young people with hip-related pain, including femoroacetabular impingement syndrome, actually demonstrate differences in range of motion compared to individuals with pain. But we couldn't even agree on that statement. So range of motion is pretty controversial in this area. A little bit less controversial with strength. Very clear that those with hip-related pain have lower strength in adduction, abduction, flexion, IR and ER, but conflicting evidence about extension. And it's possibly because extension is really hard to measure in a valid and reliable way. But we do recommend measuring strength using objective measures. So coming back to the force cohort, we're trying to answer some of these questions with the data that we have in the force cohort. And what we found when we looked at the range of motion in this cohort, and remember that they all have a positive fader, but they don't necessarily have hip-related pain. They don't necessarily have femoroacetabular impingement syndrome. So they had a positive fader, and they were included in the cohort, but they may not have a CAM morphology. Some of them don't have a CAM morphology. And what we found is that in those that had CAM morphology and symptoms, their internal rotation range was lower. But in those that didn't have a CAM morphology, there was no difference between those that had pain and those that didn't. So this might be why we have this conflicting evidence, because this is the first time that we've looked at interaction terms between symptoms and CAM morphology, symptoms and sex. And we also found sex-related differences in the relationship between range of motion and symptoms. So total rotation was lower in women with symptoms, but not men, and BKFO was lower in men, but not women. So this maybe explains why we've seen this conflicting evidence. Perhaps we haven't been analysing the data in the correct way. We also found what we expected with the lower muscle strength for IR, ER and adduction, and hip abduction strength was lower only in the Australian football players, not in the soccer athletes. Functional performance, everyone agrees that it's impaired in those with hip-related pain, and we should assess this in clinic, particularly reduced squat depth, impaired performance on single-leg balance tasks. So star excursion balance test is one that's been looked at a lot with hip-related pain. There's conflicting evidence on hopping, but since the consensus, we've had a little bit more information about hopping and showing that it might be valuable to include in assessment. And what about returning to sport or performance? We found that around 90% return to sport after surgery, but only about 20% come back to full performance. And that the return to sport continuum is rarely used in hip research. So this is something we really need to do with our future studies. There's almost no evidence on return to sport following non-surgical management. So this is another big gap that we identified in our consensus. It's important to quantify patient expectations on returning to physical activity, which is a bit the same message that Lynn was describing, and we need to use this return to sport continuum in our research. It's very helpful to use sport-specific activities to assess them and to guide return to sport, and all of the criteria-based criteria prior to return to sport as described by Phil and Lynn. So we have growing evidence on the standardised methods of measurement that we should use, what is effective at differentiating those with and without pain, and we can take that forward into the clinic. All right, what about management? This is what everyone's here for, isn't it? So what's the aim of non-surgical management? Education is essential with these patients, especially with long-standing adductor-related groin pain, but also with hip-related pain, and bring the evidence in. A lot of people will come to my clinic who have seen a surgeon, have had a CAM morphology diagnosed, and have freaked out because they've gone on the internet and thought they're going to need a hip replacement by the time they're 30. So bring in all the evidence. Bring in the evidence of this disconnect between the imaging findings and presentation, and education that this is going to take time. We need at least 3 months of rehabilitation. We want to reduce pain. We want to restore the impairments, all the physical capacity that I just described. And then we want to reintroduce sport-specific retraining. And just as Phil was describing, we need to make sure that they're training at the loads and participate in the kind of skill-based training that they need for their sport. Otherwise, the rehab is going to be unsuccessful. What are our principles? We have general principles that are relevant for all of the categories of groin pain. And it's quite surprising because when you see my exercise, they're actually not that different from Phil's hamstring exercises. And then we have some specific principles for that specific groin pain and the presenting impairment. So it may, even though you and I may both have adductor-related groin pain, your impairments may be different to mine, so therefore the rehab will look a little bit different. But the other thing that will look different is our age, our level of play, the position that we might play on the field, who our coach is, what our demands are, match schedule, and what is our training age. So what's the history of our injury history, but also the age of our training. That will all factor into how quickly or slowly you progress through the rehabilitation. So adductor-related groin pain is the most common category of groin pain. If you work with football, about 70% of your athletes presenting with groin pain will have adductor-related groin pain. So you need to get good at managing adductor-related groin pain, recognising it and preventing it. And we have really good to excellent results for exercise-based management of adductor-related groin pain. Our rehab needs to be directed towards the impairments, and we use our valid outcome measures to determine exercise progression. So things like HAGOS, but don't make them do it too often, because you start getting donkey votes. So you really want to save HAGOS for, maximum every 2 weeks, preferably every month. And then we have all these sensitive pain provocation tests, which have been very well researched in the groin area, and these can be used to determine load progression. So you can see the response to load, do the test. If their pain's gone up, maybe you just stabilise at that load. If the pain's okay, maybe you can progress. Per published his protocol a long time ago now, still relevant. The only difference is that that was a time-based protocol, and now we use more criterion-based protocols. And Andreas published this a couple of years ago. It's based on acute adductor injuries, but really relevant. The actual exercises and the progressions and the criteria is really relevant for all long-standing adductor-related groin pain. We have actually 2 RCTs that have looked at compression shorts. They work. They reduce pain. People like wearing them. It's an easy thing to do with your athletes if they present with adductor-related groin pain. And hey, no harm, right? Doesn't reduce their skills or abilities. Chuck on their compression shorts. There's also, surprisingly, evidence for efficacy of manual therapy. And no evidence for dry needling, but it is used a lot clinically with these athletes. And then we want to, once we're trying to reduce pain, then we need to load the tissue. And we use our principles of mechanotherapy and load the painful motion. And we do it gradually, and we do it with low levels of pain. It doesn't need to be 0, but we don't want it to be higher than, say, 2 or 3 out of 10. And Andreas published this fantastic paper a number of years ago now, which looked at EMG, describing the best exercise to strengthen the adductors, depending on whether you want to really work at a high level, isolate, that sort of thing. And my colleague, which is actually Associate Professor Joanne Kemp, published this paper as part of the consensus statements. Jo's been working out what's the optimal form of non-surgical management for hip-related pain for the last 14 years, actually. So she really is the world expert on this. There was a number of systematic reviews that compared surgery, in fact the same 3 RCTs comparing surgery with non-surgical management. I like this one from Nicola because he's the first one that looked at only the physical therapy and showed that we can manage these patients non-surgically and be effective. Maybe it's not quite as, with the management that they were used in those studies, not quite as effective as the surgery, but equally it was effective. So what management for hip-related pain is most effective? Well, when we look at comparisons of physio versus sham, we find that if you only manage for less than 3 months duration, not so effective. But when we start looking at greater than 3 months duration, then we start seeing some decent effect sizes in the change. The level of evidence here is limited. It's hard studies to do. But we do see improved function with exercise interventions that include targeted strengthening and are more than 3 months duration. So that's your take-home message. Use proper strength and do it for more than 3 months. When you look at within-group changes, we've got a little bit better evidence. So this is, so rather than RCT evidence, this is just the arm of the symptomatics. That PROMs improve, there's a moderate effect at 3 months, even better at 6 months. So that's why I say this takes time. You need to give time before giving up. And that's a big effect size, right? We need to consider program prescription. Same messages that Phil's saying. So we need to think about load, number of reps and sets, the duration of the whole program. There's no point in sending athletes home with a program that takes them 2.5 hours to do and they have to do it every day. The duration of each repetition, time under tension, rest, range of motion through which the exercises are performed, particularly critical for hip-related pain, and how many times per week should they complete this program. So all of this needs to be considered when you're designing a rehab program. And we had some decent guides, such as this one from the ACSM. So in early rehab, we really need to focus on abdominal function and pelvic position awareness and things like lateral pelvic position to really gain that proprioception of where their pelvis is in space. And we use isometrics again as pain modulation. And for no particular reason except that this is just my clinical experience, this is the protocol that I tend to use. 30 seconds, 3 reps, 4 times a day. And I do that for a minimum of 2 weeks. And I often will send hip-related pain patients away with this and then start their rehab program once their pain's dulled a little bit. Most of the pain with hip-related pain is related to the tendinopathies around the hip. We need to progress their strength. We start with things like isometrics, then low-load inner range, and then quickly move into standing, more functional positions and add some load. TheraBand should only be used really in these initial stages though, because you can't control the load and you really need to make sure that they're progressing. And it's very hard depending on the colour, the band breaks and suddenly they move in like this and the resistance changes. And you want to know how much resistance they're imparting on their adductor muscles. So we need to progressively load through resistance. Remember that athletes need proper strength and power. Not enough with these little rubber tubes. And we need to make it more complex, use things like the Copenhagen adduction slide board to really build the sort of requirements that they're going to need from the hip and groin when they return to sport. Same principles with hip flexion strength. So this is your psoas-related groin pain. Isometrics, moving through to isotonics, through to reverse Nordics as eccentrics. Hip extension, low load, progressing through to some increased resistance. And then you've got to whack those weights on. You've really got to load their hip extensors. Our glutes are incredibly big, powerful muscles. You have to load them. So using things like bridging, hip thrust, love this exercise. And squats, you can start really early, but just make sure you're really careful to keep under the 90 degrees with hip-related pain. Important to have really good endurance with the abdominal and core function and use your imagination as to how to create more impetus to these muscles. And make sure, as Phil talked about actually, that they have this control of rotation with the abdominals. Rotation of the trunk is really essential for most sporting movements. You want to make the movement more complex, adding things like single leg deadlifts, maybe a Bosu, lunges, love lunges, so good for retraining that movement quality. Add things like unstable surfaces, etc., to really challenge their balance and proprioceptive systems. And don't forget the other groups. Every single one of my hip and groin pain patients gets calf raises, and now Phil's told me why that works, so it's really good. Think about other risk factors, things like Nordic hamstring exercises and ankle proprioception, particularly if you're looking at football players. We know the most common injury is ankle, actually. So if we send them back on the pitch without having done any ankle proprio, they may end up being great with their groin, but do an ankle. And always maintain their cardiovascular fitness and prepare them for the load they're going to get back to. In mid-stage rehab, we want to become more dynamic. Sorry, Mario. We want to add resistance, dumbbells and bands. We need to add some plyometric action, increase speed and increase range. We want to think about the planes of motion. So particularly with hips, they're much more comfortable with sagittal plane motion than coronal plane motion. And lastly, they don't like horizontal plane motion. So think about that when you're designing a rehab. Start with the sagittal plane, then move into the coronal plane, increase the complexity, increase the load, increase the speed, increase the dynamism, so that they're getting ready to get back to the kind of activities that they're going to do when they go back to their sport. And then horizontal plane is tricky, and it can be the thing that trips you up at the end. So do it nice and gently, slowly, and bring it in when they're pain-free with all their other activities. Important to retrain landing. A lot of our sports will require landing skills, and we don't want them to do an ACL when they come back. Oh, there's my alarm, sorry. You don't want them to do an ACL when they come back to sport. And after all, they might need to come back to this. So this is what you have to prepare them for, right? You have to prepare them for landing. End stage is more sport-specific training. Again, think about those planes of motion, the requirements for their sport. Think about the fatigue elements. We need for them to be able to tolerate long sessions of training. So when you're doing your rehab preparation for training, you need to make sure that it's sort of simulating a training session. And our normal training principles of high, medium, low load and rest days. Important to include a lot of change in direction drills, whether it's whatever category of groin pain or hip-related pain. We have some great guidance for both kicking, swimming. Important to include performance maintenance, so introducing whatever sport-specific skills that you can. So if they're a water polo player, they can be throwing balls on land if they can't do egg beater. So keep them training as much as possible. Same thing, same message that Phil was talking about. Keep them involved with team training. If they can't actually be on the pitch, they can be collecting the balls. Keep them involved, and maybe they do some performance simulation if they're a gymnast, or video analysis if they're in a team sport. Load management principles. Think about the type of load, the volume, intensity, rate of increase, and some of these extrinsic factors which can sometimes be out of the control of the support team. And as I mentioned, really important to spend time talking with your patients, and keep educating them, keep supporting them through that process. They'll get very frustrated if they're not progressing as well as they want to be. Assess their psychological readiness to return to sport, and consider and respect any sociocultural factors which may be relevant for them. There could be a lot of fear of recurrence. We know that we have a really high recurrence when it comes to hip and groin pain. And robustness for hip and groin pain in athletes. Finally, as I mentioned, I discussed this for the whole talk last time, so I'm just going to do a brief summary. We have primary, where basically everyone's healthy and we give this to the whole team. Secondary, where we're doing monitoring and trying to pick up those at early signs that someone's starting to struggle. And then tertiary, they're injured and we want to make sure we prevent recurrence and do a really, really good job with their rehab. We have good evidence now for primary prevention. Christian was able to show that the FIFA 11 Plus on its own was pretty good at reducing prevalence of groin pain. And then we had UR's study, cluster randomised controlled trial, where they introduced just one exercise in addition to FIFA 11 Plus and found the prevalence of groin problems when they considered not just time loss but any presentation of groin pain. They had a 41% reduction in the intervention group. Pretty good evidence that primary prevention can be successful. We also have some evidence, just emerging low-level evidence for secondary prevention, where if you think about the relationship between intrinsic and extrinsic risk factors and use something like this alert system, where you have a drop in adductor strength and maybe an increased pain on the Copenhagen adduction squeeze or Hagos scores, and implement at early signs this multimodal management plan, which may be reducing load, may be adductor strengthening, depending on how the patient presents. You can have a significant reduction in the prevalence of groin pain in youth athletes. And we also have fantastic evidence for criterion-based rehab being effective at reducing recurrence. So to summarise where we are with prevention, we have good evidence for the Copenhagen adduction FIFA 11 Plus. We have good emerging evidence for the efficacy of monitoring, and good evidence that an effective criterion-based rehab program can reduce the incidence of injuries. So to summarise the whole talk, we do have some standardised terminology, taxonomy and classification that has evolved over the last 8 years. We know that we have some good measures of physical capacity that are good at differentiating between those with and without pain. We have growing evidence of the efficacy for exercise-based management for hip and for groin. And we need to use our training principles to design and progress our rehab program. And we have pretty growing evidence in prevention. So we always need to keep the athlete at the centre of our care and individualise. So thank you again to Sport Physio Swiss for inviting me, to the best host in the world, Mario Bazzini, thank you, and just thanks to all my team at La Trobe. Thank you.
Thank you, Andrea, for this interesting presentation. Are there some questions in the room? Someone that wants to make a question?
Maybe I start with the Slido question.
Sure.
Where is the place for plyometrics in injury prevention? Do you think there's a need for that more?
It has not at all been investigated. Mm-hmm. Do I think that there's a role for plyometrics in injury prevention? Perhaps for hip-related pain. I think for groin, like the clinical entities of groin pain, probably more things like change in direction, high-speed actions, kicking. That seems to be some of the factors. But when we looked at the video analysis for the acute adductor injuries, we did find that a small percentage were from jumping. So jumping and landing retraining is important in terms of the mechanism of injury and important in terms of rehab. So it probably makes sense that it should be also included in prevention, but it's just never been investigated.
Okay, thank you.